So I've given you some slides and I'm going to actually present um, both of the decks, and then we'll just kind of talk a little bit more about what this means again for your understanding of the work of the lab, but also kind of how to use this information in your projects. So this first deck is a very long one. It's very detailed, and it is a quite a detailed kind of examination about what is the people integrated care model all about, what's the theory behind it, what's the evidence behind it, what are we trying to do with it, where do we see it going next. So this is basically just getting familiar with the key concepts and some of the foundational underpinnings of this model, and then how it's reflected in the data, the research work that we do, the program design, and the tool development work that we do. Um, Mainly, we use this kind of for our own purposes, that we all who kind of work in this space have a really good understanding of what we're trying to do. When we go out to communicate it to others and find those first followers and try to invite them into sharing kind of the experiences and the learning about why we think this type of cultural change and this kind of social movement and this kind of support for really kind of directing your own self-care and your own self-healing, as we'll hear Sharon and Robin talk about tomorrow, why we think it's so important. We have different ways of kind of doing that knowledge translation, or simplifying the message so that it makes it more accessible and more easier for people to kind of get excited about. Again, that simple dance movement there of the original nut in the video that we watched this morning. But again, to fully achieve kind of that public health impact, we have to be very kind of intentional and strategic about the choices that we make. So that's what we're going to learn a little bit more about today. I'm going to go through this really quickly. If anybody has any questions, just ask them as we're going through the slides. If you have questions later on, that's fine. We can talk about this in future meetings, or you can also kind of email me. So anyway, so you all know who we are with the Health and Wellness Friendly Communities Lab, and there's some materials um, in your projects that kind of set out how we present ourselves externally. But anyway, again, as I mentioned at the beginning, we're really kind of in that incubator, testing, design, and development. We're not a service delivery organization, but we do really want to see the impact of how we deliver supports in order to model whether we think we're on track for achieving that public health impact. So this is kind of like our whole theory in the 5-second version, which is almost all of the care that people receive, need, and want is actually informal. Like, take the money equation out of the mix, take the payment out, and people are kind to and care for others in your friendship circle, in your family circle, in your community circle, and people are motivated by concern for society and human development, which is why you're all pursuing the careers that you've chosen. And all of that is what we call informal care. It's caring for others in very small to very large ways, and doing it because that makes us better humans and it makes the world we live in a better place. So people, humans, beings who do not have access to their own personal community and informal care resources compared to others, have much worse health and societal outcomes. use health resources and social welfare resources at greater levels and experience greater levels of inequality. So we think that we don't really kind of picture it that way, but we think that that's really the driver that differentiates those who have better outcomes compared to those who have the worst outcomes. So we think that this model of people integrated care is part of the solution. And we have research that demonstrates that human and community capital, even though it's very organic and dynamic and generally taken for granted, it can be defined, it can be visualized, it can be organized, and it can be nurtured and supported to meet more of those day-to-day care needs that people have for self-care, for practical support, for social connection, for mental health, and to advance their own kind of personal goals, as well as better address social determinants and other equity concerns of a wide number of important kind of subgroups and populations. And in terms of the impact that we're looking for, so we believe on a small scale, it's already demonstrated. We're looking to demonstrate it at a much broader population level, but we want to see people across the entire life course from birth to death. We want to see how support for visualizing, for organizing, for nurturing informal care resources, what effect that has on health, happiness, and connection. What effect that has on care providers, either informal and families or service providers and organizations, in terms of levels of stress and distress. And we want to see the impact it has on use of health system resources and community resilience. So we believe that in terms of where we are right now, a modest investment of time, use of existing tools, and some additional accountability parameters would be enough to kickstart efforts to build such a system. And for that, we need to increase awareness and visibility of that informal care network to make that part of people's actions. To measure and make transparent person-based quality of life outcomes at multiple levels, at client, at organization, at community, at system and population levels, all with those feedback loops for quality improvement. We want to integrate as much as we can those informal and formal care resources across many channels, leveraging human and community on ingenuity to develop new capacities and new resources to meet more of those unmet needs and help remove barriers and celebrate early wins. So there's room for everybody in this movement. This can happen both in parallel or integrated with existing system initiatives. And it's a really low cost, low risk proposition with significant human and public value upside. So that's why we're doing the work that we're doing. Okay, so the fundamental challenges that are currently undermining population health and how we think the solution addresses them. Well, we all know this about people are not as healthy as they could be, and a good part of what drives those poor health outcomes, morbidity, mortality, premature death, are social and behavioral. It's not, there is access to health services or treatment that obviously is an important part of the equation, but there's also a number of areas that if we could tap into are preventable and would address people's social and emotional health and have those effects again on disease onset, disease burden, and premature mortality. Canada's care system is weaker than it should be. People don't have access to the support that they need. We know that health is multidimensional and only one component of well-being. So we're interested in health, we're interested in wellness as well. Again, health doesn't come from healthcare provision. Response to treatment does, but there's a lot of other aspects of health that can be supported. Gaps in care that are of concern to a lot of vulnerable populations tend to be things like practical support, social relationships, activities life purpose and meaning, dignity, comfort, etc. Um, Social and healthcare integration in the academic literature, there's a lot more attention to it, and it is growing. But to do this within kind of the formal service mode through professional care resources is time and resource intensive, tends not to be as preventative as it needs to be for public health. And it's mainly available to only those who are kind of most unwell. So again, kind of missing out on that opportunity for health promotion. So basically kind of the proposition of the researchers who work with us in this lab space is that to achieve quality of life and well-being for the majority of people across their lifespan, informal care must be central in all care models. So how do we go about changing the paradigm so that we focus more on prevention, on wellness, on person-directed goals? So here's just a little cartoon to say it's hard. You know, again, kind of round wheels are more efficient. No thanks, we're really, really busy right now. We've got no time to kind of think about that or look at that because we've got to move really fast. So that's kind of the space that the healthcare system and social welfare systems are operating in. They're really busy, they're really trying to change from within, but it's really hard. And they have really kind of limited attention span and capacity to take on new, what they might think are kind of relatively untested, unproven new ideas. Because new ideas are a dime a dozen, but how it really kind of affects and benefits their work takes time to figure out. So basically, kind of in the typical innovation within formal systems, when people like policymakers and system leaders are looking at new solutions to deal with these really important, urgent problems that these systems are experiencing. Typically, it starts with a design shop that develops like a new thing, a new drug, a new process, a new tool. It's pushed out to very select beneficiaries who are very similar to the group that the tool was originally designed for. And that achieves very small, important, but really incremental gains. So our work here in the lab space is really kind of that invitation to think really differently about the way you think about problems, the options that you see for addressing those problems, and the choices that you make. So we think that one of these kind of options and one of these behavioral choices is really to look at, you know, the informal care resources across physical, mental, and social health domains. So it's a little bit more complicated, but this process combined with what we just saw about, you know, the system level innovations being pushed down, it's that combination where it meets in the middle that we think has the best opportunity to achieve that public health impact. So our work starts with each person, and we use kind of a number of different tools and analysis techniques to look at those patterns and resources that combine in this kind of network of care. And then we look at that capacity to explore those patterns and see how not just that personalized individual can benefit, but how it plays out at those group and population and systems level. So discovering and using that process to discover new partnerships, to locate people who are much harder to reach, much more isolated, much less likely to be found in the typical types of programs and resources that exist currently, to identify key players and champions who are going to take this movement forward, you know, kind of those first and that group of early adopters, and then to target those network subgroups on more kind of customized support for how they can implement. So what a high impact care system looks like in this people integrated care model. Oops, sorry about that. Hmm. So it's a model where we actually try to, this is again all the type of care resources that we're trying to value, to recognize, to nurture so that they can um, really be leveraged to help people to the degree possible. So again, the idea that people should be able to count on neighbors and friends for extra help, that the communities should be communities of any definition, not just geographical, should be able to wrap around people in distress and figure out how they can help them, that people and their care partners find it easy to help themselves and are truly in charge of their lifelong care journey, that formal care, friends, volunteers, self-care, and technology, those are all the components of that personalized care network, work collectively to achieve that person and family's most important goals. And then that the community can use its capital, its human capital, like again, social capital, built environment, financial resources, etc., all of the capital available to it wisely and measure itself to ensure good quality of life is within reach of all community members with extra care for the most vulnerable. So that's what we think a people integrated care system should look like, that is compassionate and encompasses both health and wellness. So to get started, again, the seeds of transformation, that's kind of the stage that we're working in now. So that idea of the Kickstarter efforts, the increase the awareness and visibility of what constitutes informal care around individuals. And then if we have enough data to look at those patterns of care around some of those kind of key target subgroups and harder to serve demographics. So, well, with the idea that while each person's individual network is 100% unique, healthy patterns can be identified. And once we know what those healthy patterns are, we can support access to more people who are, again, kind of more isolated with those new partnerships, etc. So again, this is just an example that in terms of people's day-to-day care support for social and emotional, as well as mental and physical health, that people do rely on services, but actually very little time is spent with professionals and formal services in terms of day-to-day life and living. But a lot of time might be spent with family and friends, and for people who are highly isolated and don't have those family and friendship circles, a lot of time might be spent in community and social activities and environments that encourage that kind of connection and social participation. So again, there's multiple resources that could be brought in to achieve that, that equilibrium of I feel I have the support I need to be as healthy and happy as possible. It's just that when it doesn't work, there's very little support that's available within traditional services. And that's really the model that you'll all be exploring in terms of the education, the program evaluation and research that we'll be doing over the summer, and the policy research. So not everybody needs the same kind of support in order to, be in charge of their lifelong care journey and make sure that they've got the team they need to help them achieve their person-directed social, mental, physical health goals. Support can be either preventative, ameliorative, or both. So this basically just says where people are highly complex and have a great number of health needs and disabilities. They need they do need their professional teams and their professional services. And this could be kind of one element of the care model that's built into that complex care system. It's obviously not enough as a kind of a standalone, separate system that, given those complexities and those risks and those high level of need, the more it's integrated, the more effective it'll be. But at the bottom, for a health promotion approach, being able to communicate, share information, talk to kind of friends and neighbors about opportunities, that community culture of being able to normalize these kind of conversations and signpost helpful resources. That's very kind of health affirming, and that is eventually what we want to build on so that we can see what the value of some of those preventative approaches are. So at the bottom of those kind of level 0 and level 1, there's a lot of work that can happen in the public health space just through sharing information and sharing kind of knowledge and getting people interested in the knowledge. As people again experience greater levels of risk, have kind of more complicated circumstances, a lot of work can happen through volunteers to kind of build people's capacity to organize their care in this way. And then, as I said, at the highest level of complexity, a lot more attention to kind of those systems of integration should be paid. We've got a lot of programs and tools available. Again, like as we work through the training, you'll experience all of these, but this is just a little summary of the things that we've been designing and testing and working on to date. The second catalyst action that we wanted to mention is this idea of every human to human interaction should have benefits, in terms of that relationship, but it can also be translated into data that at the back end helps a person measure and make transparent what their own quality of life outcomes are, and then kind of through that analysis process can be aggregated to look at individual program, population level, quality of life outcomes, and build those feedback loops for quality improvement. So again, all of the work that we do is not just about, helping people through that process of personal narrative and looking at their personal care network and thinking about being aware of what they think about their own social, physical, mental health today. We also then want to turn it into data at the back end. So it's that conversation that generates kind of the knowledge, the person-directed knowledge that we can turn into data and give it back at those different levels as part of that feedback loop. So we talk to people about, their perceived health and quality of life. We can talk to caregivers about that because, again, that's part of we believe that care providers would experience less distress. And then we can also look for that public value equation. We could look at how people are using certain kinds of both system and community resources right now, and how that pattern of resource use might change over time, especially as they're nurturing and developing their own informal care network. And again, that happens at the individual level, and then at this kind of network level or subgroup level, we could look at different populations with different shared characteristics to see whether how those equity differences are being affected as well. So, so you'll all be using, hopefully we'll be getting it back online shortly, but we developed kind of a data platform to manage all of that data and reveal those kind of patterns. And that's what we use for program evaluation, although kind of in the last few months, it's kind of been offline, but we hear it'll be fixed this week. But anyway, the idea about all of that data can be entered into this data platform that then kind of gives us insight into the value of the technology, the value of kind of that network on those individual outcomes, that resource use, that caregiver experience, and that's the data that we could use to give feedback to organizations about how effectively they're working with people who experience loneliness or other social health deficits. It's the kind of data and feedback we could give back to communities about, use of social capital and the development of new community resources. We could use it for system level change and population health uh, analysis, and we use it to kind of fuel um, more effective, more powerful technologies to make this kind of support and service available to more people. So again, each community and each individual's experience is unique and customizable, but those patterns emerge when you look at those larger community and population levels. So the integration concept, again, is another kind of thread that runs through. So obviously, like, people need help. Lots of people have very kind of complicated situations that can't be solved, obviously, just through their own kind of personal resources. So it's that kind of wrapping all of these types of assets together and focusing them on that. What difference can we make to people in terms of health and happiness, working more collectively together? That's a research question that we're trying to explore. So again, it can be built into lots of community initiatives that are organized around that concept of neighborhood outreach, neighbors helping neighbors. There's lots of faith communities. Many of them kind of are involved in that kind of space. So that's a key resource that communities are doing. That outreach to the most vulnerable. There's lots of groups that are really concerned on those really kind of hardest to serve, hardest to reach populations. That's an asset that can be mobilized. Obviously, like this idea of self-activation, self-care, people who are motivated and like exploring kind of these new or these ideas about how they can be as healthy and happy as they can be. That's a resource that can be integrated, and again, the basis of like an education program like you'll hear tomorrow in our Tuesday session. The combination of this with health, social, municipal services, and all those other kind of care networks that are emerging in the formal system space is important. So that's the kind of the informal and formal integration. Innovation, obviously, because this is not a solution that it's an emergent solution. It's not something that's really established. So it's a constant feedback loop that powers new innovations and new ideas to make it easier and more impactful. And everything is kind of built around this idea of the learning health system, where every piece of data, every piece of feedback goes back to say, are we on the right track? Are we learning from that data and using the data to be as effective as possible, and also kind of using the data for that quality improvement focus? And again, as I said, kind of it's that mixture of all of those solutions happening at the community or system level, coming down to all of the support that's directly to people around their own kind of self-education. And somewhere in the middle, we're going to get those support systems that actually are truly effective in that kind of public health model around the health and happiness that happens as part of day-to-day life and living, where community and self-care and all these resources are wrapped around each individual's own goals. So just in terms of, kind of the leadership, it's around those accelerator actions around creating that movement. And again, kind of some of these you saw in the little video earlier, but around that kind of that sense of urgency, around that big opportunity, that fun new idea, the first followers and creating that guiding coalition. That's kind of what we think our lab space is, and all of the researchers that work with us and all of the student interns that we're so pleased that we have an opportunity to work with, drawing people in from all different kinds of backgrounds with different types of strategies and ideas, and that forming the change vision and that set of strategic initiatives. So that's our change vision, the idea that people can be supported to be healthier and happier, and the strategic initiatives are the tools and the programs that we're working on right now. And now we're in that space of finding those followers, enlisting that volunteer army, and that's why you're an important part of our solution. Figuring out how to remove those barriers and advance those opportunities and do the research so that we can really kind of celebrate those short-term wins and build that evidence base. And then moving forward, it's around sustaining acceleration and institutionalizing change. So that's our system transformation, our policy research agenda, infusing the changes into culture and systems. This is kind of from a book, John Cotter, about models to to how to accelerate change from within and outside systems. This is also kind of a framework that we use around um, how we become part of building that movement, not just kind of building kind of a few new tools and programs. So in terms of the evidence base, so we do have some pilot studies. We've looked closely at the work in Froome in the UK, if anybody's kind of read anything about that. So Dr. Julian Abel, Lindsay Clark, and others have written about this extensively, and they're actually kind of some of the original innovators of the idea that a whole community can organize itself to meet the social health needs of their entire population, and by doing so, that has a dramatic effect on decreasing use of unnecessary health system resources. So what they demonstrated over a 5-year implementation period in Froome was 17% fewer emergency hospital visits at an entire population level. So every resident of Froome, which actually is a tiny township, so it's easier to organize this at kind of the scale that they were able to work with in Froome. But nevertheless, the outcomes are real, and they point the opportunity for us to kind of potentially replicate some of these outcomes in the communities that we're able to work with. So even while Froome in this 5-year period was significantly decreasing emergency hospital visits, other little towns across their region or their county in the UK experienced a 28% increase in hospital visits. And then again, they did kind of qualitative research that showed the residents really, really liked this model. So they did an economic impact study as well and showed a 21% reduction in healthcare costs. Like again, that's a reduction of costs in the healthcare budget, not just on people who were part of the intervention, versus that 21% rise across the county. And the enablers that they pointed to as being of critical importance were around co-creating solutions with local people, building those community partnerships, training people to support others. So again, the kind of training work that we do with you as interns around training you to look for opportunities to support people in this way, and then proving that impact for validation. So again, like it's the same kind of messages that they had the message, and you see how we have picked them up in the development of our model. So we work We do a lot of work with kind of a lead agency that we have in the Windsor Essex area. Right now, our lead agency is Community Support Services of Essex, but we previously did a lot of work with Hospice of Windsor Essex, and we did a 3-year pilot study with hospice. And we also kind of our own program evaluation data showed significant changes in increase in perceived health, ability to do usual activities, progress in achieving goals, number of social contacts, and kind of normalizing kind of that wellness support and wellness seeking behavior with significant, statistically significant decreases in perceived loneliness, use of ER visits, and stays in the hospital. We've done some qualitative research that looks at really kind of the importance of this kind of respectful support to people and paying attention to those little things that make the quality of their life better. And what that evaluation study found was that our program, which now we call kind of quality life conversations, or you're going to be trained to do it as part of a phone support program. But this program acted as a safety net for people who are falling through the cracks of the formal care system, that little things often had the biggest impact on client well-being, and that a significant enabler was taking the time needed to navigate helpful resources, empowering clients to set personal goals for health, and making those authentic personal and community connections. So you'll see how that's played out in terms of what we're now calling the activation pathway. So that form of not just kind of signposting community services that might be available or activities that might be available to that person, but really looking at that authentic personal self-care approach, so that the volunteers also benefited from experiencing and responding to the needs of the community's most vulnerable members. So it's not just that our ability to help others, it's kind of the idea that we're all receiving help while helping others at the same time, and our ability to offer help and care for others is actually part of an investment in our own health and happiness. So okay, so if that's kind of where we're at, we're still kind of at that, kind of early days, that kind of still kind of building the evidence base and exploring kind of growth opportunities. We're nowhere near the tipping point yet. But what is our implementation framework? What do we think are the opportunities for scaling up and achieving kind of more of the population level impact? Well, so then we looked at kind of the models and the theory driving this kind of approach, and we looked at those kind of strategies that are inherent in the public health model, and we kind of did some work kind of looking at a few other models of interest to us, like accountable communities for health, etc. And we think that there are several really important strategic aims, that we need a model that empowers people, families, and communities. It doesn't just kind of impose services on them. It lets people, families, and communities really kind of design their own solutions, but within some guidelines, within a framework. It strengthens care, and it builds those enabling environments where, again, there's little risk for neighbors jumping in and helping each other, and there's little risk for people kind of really expressing the help they need because they feel confident and they trust that the community will find a resource that will be helpful. That reorientation of the entire kind of model of care, from sickness care to prevention and wellness support, and again, kind of powering that learning system. So the measurable outcomes, again, kind of happen at individual, at group, population, and societal outcomes. So this is just another way of kind of saying those quintuple aims of the health system are really important for us as well to measure the difference and kind of demonstrate the impact so you can get people interested in it and sustain that kind of that growth and build those kind of partnerships. So this is kind of just a representation of what people integrated care looks like. It's the idea of combining kind of the person's own goals for health and well-being, looking at that specifically from physical, mental, and social health lenses, and then looking at resources or opportunities within informal care systems, specifically kind of neighborhood level care, community led types of activities or resources or supports, and what's available within families, combined with formal healthcare or social welfare services or other kind of formal care services that the person might need. Again, that's all coordinated and integrated through the person's own leadership in terms of identifying what's most important to them. And then where our tools and programs fit in is the ability to share that education, that support, that information that empowers individuals and organizations and communities to behave in this way and organize care in this way. So the intervention components is a little bit of that general public education information, the type of, Be Happy, Be Healthy education series that we provide, tools like our social health screener, groups like the Connection Cafes, and some of the general wellness programs that we provide. But when we also kind of try to partner with organizations, we look at different demographics that are served through different kind of policy sectors, then that gives us the opportunity to look at the basket of services that's available to people through kind of multiple different kind of sector lenses, to look at target population. So many of you have a specific demographic that you want to explore working with over the summer, which is great. But we look at the delivery mechanisms of how to connect and reach those people and look at what's realistic in terms of kind of our model and how it could be operationalized for their benefit. And then we look at how to do that outreach, how to engage people in doing that self-assessment, self-reflection about their quality of life from social, physical, mental health lens. What's of interest to them in terms of activation, support, and education, what their own kind of network of care, how it can be visualized, and if there's any gaps in there that they want to address, what kind of resources and information allow them to kind of reach out, reach back into their communities and find resources and activities that they can invite into their network to address those unmet needs. And again, those feedback loops so that individuals have information, practical information about what steps they can take, how they can improve themselves. Organizations have the same kind of feedback about, are they having an impact on their clients, especially the most vulnerable members of their client target population, and what's that looking like at the community and population level. This is kind of complicated, but it's just a demonstration that these kind of tools and interventions, those intervention components that we just talked about, actually fit very well with health system quintuple aims. And we're always trying to work at those 5 outcome sets about achieving better quality of life for people, building that community resilience, that experience of care, and achieving that cost benefit of reduction in kind of unnecessary public resources. So the economic driver is kind of using that idea, that opportunity that Froome presented. If in fact a community at a population level, if it's organized and defined sufficiently, if it's possible to both achieve better quality of life and achieve that 20% reduction in average healthcare use, um, then there's the ability to fund this model and sustain kind of growth and scale up. So the economic driver really is around that organization of that expression of what's important to me, what kind of care do I need, that building the capacity in those communities to address those unmet needs through leveraging social capital and other assets that are already available in communities, not always kind of just throwing more of a kind of a professional program or resource at the problem, which would have limited benefit for only a small number of people, but really trying to look at it kind of at the grassroots level and build that enabling environment. And those are all of the components together that have to be shown and demonstrated in that kind of learning system approach, in terms of what are the economics of this, what is the impact at both kind of the quality of life, but also the cost effectiveness equation. I'm not going to kind of talk about that. Well, this is again kind of just the idea that there's multiple pathways that are built into this model around each person, and each family member have their own kind of personal care tool, which is kind of our Catalyst platform, where they can get feedback about steps they can take to advance goals and reduce unmet needs. But aggregated data could be used to build those pathways within organizations, and the entire, information communication technology engine really is kind of use of those that big data set about what those patterns of care look like and what are those opportunities for population and subgroup level impact, and sharing those measurements kind of through feedback loops back to people who can think differently, see different options and choices, and as a result, behave differently. This is again, we saw kind of those different levels of support match different levels of risk complexity. This is a bigger breakdown in terms of, that who's healthy and who's not, and what are some of those risk complications as people rise up that pyramid in terms of complexity, and what the costs of those delivery services are. So those of you who are doing policy research about this model will have an opportunity to read our costing paper, which basically says that this is what it costs to serve people at that level of complexity right now with all of the services in the system today. If we took that 20% reduction and we were, kind of gradually building up to that over multiple years, how do we introduce this into, this level of support directly to people for organizing their informal care? How does that look like across this risk pyramid? And again, there's different approaches for people depending on the types of care environments they're already experiencing and the types of risk factors that they're already experiencing. So it might look complicated, but the message is pretty simple, really. We do have a framework for what kind of governance, funding, accountability changes, would make this model scalable at a population level. Basically, kind of at the highest level of population, but again, we're nowhere near that right now. We actually think that a government who was really interested in this kind of model could pick it up and with an expenditure of around $50 per person per year, be able to support all of the volunteer services, all of the technology-based services, all of the access to information, and the integration in professional or clinical care spaces, with those kind of tools and strategies that we've described, in order to achieve that 20% reduction in per capita annual health expenditures per year at scale, Again, it's a very, very low cost proposition for quite a significant upside. You know, the value of that 20% reduction is around, you know, $1,500 per person. So there's a big, you know, potential upside. But of course, you know, you have to kind of work through it. And it's not something that you would see an overnight change. So it's a much more kind of gradual change. But anyway, when you're trying to kind of work at kind of the system level, and introducing something that is very different from the way the system behaves right now, you have to pay attention to all of these things, the short term, the medium term, the longer term policy action in order to get to that place. And you have to build those strong foundational roots, so that those existing pilots, those existing community leaders, those champions that are there now can be supported in sustaining and growing and doing the work. So where as lab researchers then, you know, kind of where we are in terms of the back end, this is our theory of change. And it, we published it earlier and we've kind of updated it a little bit since then, but it's around actually healthy public policy, um, needs governance, it needs accountability, that we see this as a complementary and reinforcing policy and set of strategies that are aimed at public health, helping people be as healthy and as happy as they can be. And you have to work kind of at all of those levels, at the person, at the system, at the community, and the population level, with those strategies that we talked about earlier in order to get to those quintuple aim outcomes. So that's the theory of change and the key strategic drivers. In terms of the research approaches, you know, we still are kind of building our evidence and our research, but we've done a lot of work in terms of examining the literature for evidence and issues and frameworks that we think are applicable, reviewing programs and coming up with lessons learned and best practices that inform our choices about how to implement, contextualizing issues and opportunities and barriers, and talking to key stakeholders that deal with those groups in order to have kind of that more customized approach that we know is relevant for some of those key demographics, either because of their unique circumstances or just to know that when we say that we think this model is applicable across the life course, that we have modeling and demonstration studies and stakeholder agreement and partnerships in order to demonstrate that. All of the work that we do is around kind of this knowledge synthesis to envision this care system that we've just described at, you know, its most complicated level, but to translate it into ways that could be engaging and immediately understood by the communities and stakeholders in some of these other programs and services and care systems, and looking at the real practical, pragmatic, what can I do now, knowing that systems are very kind of complex, busy spaces that have lots of priorities that they're already working on and not a lot of energy or time or attention to pay to this. So we have to make it really compelling for them to want to get their attention. And then that knowledge translation, which is again how we write about it, how we talk about it, how we build these concepts into our education programs and presentations and all of the other stuff that we do, in terms of the projects that you're going to be working on. When I said we did an analysis of different programs in order to, you know, figure out those best practices for implementation, this is a list of some of the programs that we looked at around the world. And we have a whole article that should be published, hopefully this fall, that presents kind of the analysis work that we did. The the generalizable features for system scale that we came up with through that analysis were the need for those kind of backbone coordination organizations. It's not good enough just to expect that each type of service or agency is going to behave like this on their own, that there does need to be that mentorship, that education, that support, people paying attention to, creating that common vision and building those communication mechanisms and those feedback loops. The support has to be directed to individuals so that they can have the assistance they need in directing their own personalized care networks. Again, paying attention to social as well as mental and physical. Um, the use of volunteers and students and interns is critical in order to bridge formal and informal mechanisms that communities and users can be mobilized and need to be supported and empowered to co-design their own resources. The usefulness of virtual and digital and technology assisted options to reach more people at lower cost. The enabling environments, which is it can be seated in all of these different sectors, but again, kind of with some coordination at the back end. But primary care, health and social services, municipal, community, built and social environments, and really it's a cultural change that we're looking at. And again, kind of that data mindset, the measurement mindset, the impact mindset, to build those learning systems to grow, transform, and improve the quality and impact of all of these efforts at all of these different levels. And this is kind of our implementation framework. If anybody has looked at recently the WHO Person Integrated Health Services implementation framework, you'll see that this is quite similar, that we use those same concepts about what integrated healthcare delivery should look like, but just expanded it to recognize what we think is an equivalent, if not greater, focus on informal care system development as well. The backbone, the learning system is kind of, again, this idea of collecting that data and seeding it out to inform those choices and behavior changes at all of those levels. And just in terms of, again, kind of where we are in terms of the lab work and the uh, the evidence around kind of the theory and the implementation of this model, we're kind of here in 2025 around the customization of it. We think that we've done the theory, we've done the concept testing, we've looked at some of those critical features of implementation and looked at some of those tools and mechanisms to do the back end support and the measurement and the data analysis. Now we're into growing access, preparing a whole bunch of different case studies with a whole bunch of different demographics and population groups, and looking at real world experiences and testing out again, how to communicate more effectively and how to get people excited by the opportunity to build those more customized tools and approaches for more specific, kind of more narrowly defined populations and target groups. And after that, we'll be ready to look kind of more broadly at a spread, scale, adoption, and replication. Um, this is just a little bit of a model about, in terms of policy research, about how it connects with the healthcare transformation and some of the innovations that are going on in specific healthcare spaces, like in primary care and home care, etc. There is a shift towards integrated interprofessional teams. Um, that are community-based, that provide clinical and specialized health care. But again, when you go back to what does day-to-day care look like for most people, you see that all of those innovations just affect that 5%, that 1% of people's kind of day-to-day life and living. So our type of model is what could potentially be helpful in supporting people that have significant risks and unmet needs in all of the other kind of community space and personal space that they occupy. This is our partnership model, that this is not about us. It's working with those individuals, working with those communities, working with all those organizations in order to look at kind of how this could be combined with the work that they're already doing in terms of making sure that people have the services and supports and information and education they need to be, again, as healthy and happy as they can be. It aligns with lots of initiatives and across the board right now, again, at all of those multiple levels. So you see there's a recurring theme. We always try to work at micro, meso, macro levels, and you see that reflected in all of this theory. Here's kind of a little way that we try to communicate the potential big public impact upside for relatively little risk and relatively little cost to implement. So that's is kind of a sample of our knowledge translation work. And then we talk to people about, you know, how do they, what um, what they think kind of this informal care looks like, how important is that to people or their clients or people they work with or people that they see in their communities, etc. And again, just kind of get more input into opportunities, barriers, and see if we can kind of get some of those partnerships in order to explore further what some of those customized implementation opportunities might look like. So I am going to stop there. So I spend a lot of time talking. I hope it wasn't either too fast or too confusing. But at this point, I'll just ask if anybody has any questions or wanted to make a comment or think about anything that might have surprised you in terms of this presentation. I'll just open it for feedback. I'm actually going to stop the recording as well, so just a sec.